30 on April. And in May, we'll have more 3 or 4 meetings, because I prefer to finish this course before at the end of June, at the end of May, in order to you to have time to prepare for your exam, for your sessions. So this is the one. The second question is, I prefer, of course, I'll upload all my presentation and you can go through them. And that's why the second question is, what do you prefer? How do you prefer to finalize this course? Through individual tasks or some writing of cases or recommendation, or you prefer to make a test, final online test? This is the second question. If you need to make a, if you decide, if you select to make a test, you have to know all the information included in the presentation. And of course, I don't expect to make a copy-paste when you elect to make individual work, but anyway. You have to prepare it before 24th of May, this individual task. And then we have to arrange a meeting, and each of you should present very briefly, maybe an abstract of your individual task. What do you think about? Maybe you have to think. You have to think. You have to decide individual task. Presentation, I think, is better for us. Okay. If you agree, okay. Okay. In this situation, next Saturday, I'll upload you the list of all individual tasks. You have to select them and start trying to find materials and information in the internet, and then we'll discuss. But this very brief, I really will need to receive, I'll need to receive before 24th of May in order to go through them, to make an initial evaluation, and then to make a joint meeting, face-to-face meeting. And each of you will present individual task. Okay, this is fine. If you don't like test, I know that students don't like test. And also at the end of this presentation, I have 2 cases, and you have to work on these 2 cases. You can select one of these 2 cases and work on it, but after the next week, because you have to get additional information about about refeeding syndrome and also about nutrition counseling. So don't be in hurry. After the cases will be presented after this presentation, but the results I'll be waiting after the next lecture. So what is nutritional status assessment, malnutrition, and the dietary management of malnutrition? Maybe students from 5th grade are more prepared for this one, but we have make a repetition of your knowledge and refreshing of your knowledge. What are the factors that determine an individual's nutritional status? It reflects economic situation, eating behavior, emotional climate. It means there is so-called emotional feeding. Cultural influences also affect the various disease states on appetite and ability to consume and absorb adequate nutrients. In hospitalized patient, emotional nutrition, emotional eating, and ability to consume and absorb adequate nutrients is very important because some changes appeared when people are hospitalized. Nutritional requirements, there are a lot of physiological stressors influencing nutritional status. In healthy person, usually this is the age, it's sex, and this is physical activity, the main factor that determine nutritional status and nutritional requirements. But in sick person, infection, acute and chronic diseases, fever and trauma, normal anabolic states and growth, such as pregnancy and rehabilitation, body maintenance and well-being, and physiological stressors are factors that can increase or decrease. Usually they increase nutritional requirement. For example, in pregnancy, during the second trimester of pregnancy, the energy requirements are increased by 270 kilocalories. And during the third semesters, the requirements increase by 500 calories. And this is normal physiological status. It's nothing extraordinary. Why it's important to assess nutritional status among hospitalized person? Because hospital malnutrition or starvation is very common. And that's why in Western hospitals, there is a special team built by physician, by dietitian, that's expert, and maybe diet nurses. They're evaluating nutritional status, and then they're prescribing specific diet, and also they're monitoring the nutritional status of the patient. In our hospital, usually this dietitian is more in charge with food safety of hospital diet. Persons at nutritional risk are identified on the basis of screening information at the time of admission to a hospital. This is important. And nutritional assessment increase the effect of nutrition intervention, education, and counseling. You know maybe that nutritional status is very important determinant for successive medical treatment and medical process. Nutrition is an important factor in the etiology and management of several major causes of death and disability. Leading causes of death have a strong link with type of and amount of food consumed, and this is more before admission to hospitals. Nutrition is responsible or is related to cardiovascular diseases, atherosclerosis and hypertension, cerebrovascular disease and stroke, diabetes, and types of cancer. For example, colon cancer and breast cancer and cancer of prostate. Disease of nutritional imbalance are obesity, overeating or overconsumption of energy, iron deficiency anemia when there is a low iron in diet or where there is a problem with the low bioavailability of iron from some specific foods. Also osteoporosis and prevention of osteoporosis states early childhood and during adolescence, cirrhosis in the liver, accidents, alcohol intake, because accidents can cause, for example, acute pancreatitis, and alcohol intake, you're familiar with this. Nutrition deficiency, they're not only caused by low intake of some specific nutrient in diet, but also of inadequate ingestion, impaired digestion or absorption. A lot of diseases of gastrointestinal tract can cause impaired digestion and absorption and nutrition deficiency of some specific nutrient. For example, vitamin B12, vitamin D, and so on. We'll discuss later. Dysfunctional metabolic processing, For example, obesity, very common deficiency among obesity is vitamin D deficiency, because the requirements of obese people of vitamin D is much higher. If a normal person has a with a normal body weight, a person has a requirement for vitamin D of around 600 to 800 international unit. For people with obesity, the requirements are between 1,500 and 2,000 international unit per day. Increased excretion of essential nutrients is common in kidneys. After depletion of nutrition reserves, nutrient, it is inadequate to meet the body's daily metabolic needs. It means it takes time before all depletion processes are finalized, and there is a low circulating level of some specific nutrient in blood. Malnutrition in hospital is nothing exotic, nothing rare. Malnutrition, this is results from study among 25 academic hospitals in USA. It was 22% wasting or protein depletion. Moderate malnutrition is among 50% of hospital patients. Low fat-free mass is identified, it means low muscle mass, is identified among 37 of hospitalized persons for 1 to 2 days and 56% of hospitalized for 12 days. It means that this patient, they come with malnutrition, with depletion of reserves, and during the hospital stay, this problem is accelerated. And this is a prevalence based on the subjective global assessment care in Canadian hospitals in 2015. I even found some statistics from Bulgarian hospitals, officially published. Reported prevalence of malnutrition among hospitals in North America and Europe are between 20 and 60%. And prevalence of malnutrition at admission in medical and surgical patient is reported at 45 in acute care hospital in Canada. So it's very common. And this is the key concept in establishing malnutrition in hospitalized children. This is about children. And this is the malnutrition, undernutrition, and malnutrition based on anthropometric parameters. And for children, there is used Z-scores, and below 2 and 3 Z-scores, there is a malnutrition. And there are chart-specific WHO chart. They are used for evaluation of nutritional status and assessment of malnutrition of children. It's more specific compared to body mass index that is used for adults. It is non-illness related. It means low intake or improper intake, or complementary feeding, or early introduction of cow milk before the age of 12, and improper introduction of complementary feeding. Also illnesses, acute diarrhea or vomiting, and also chronic diseases. For example, cystic fibrosis, this is genetic inherited diseases, or Crohn's diseases, or chronic inflammation, not treated inflammation. And this is mechanism, starvation, low intake, malabsorption, nutrient loss, and hypermetabolic state, usually inflammation, fever, and the results is malnutrition, and the outcomes is loss of lean body mass, muscle weakness, problems with development, immune dysfunction, and infections, delayed wound healing, and compromised development in general, physical and cognitive development. At the other side is overnutrition. Overnutrition, it's also, if students from course 5 remember, malnutrition, it's not only undernutrition, but it's both overnutrition and malnutrition, overnutrition and undernutrition. So malnutrition, it means there is a disbalance between proper intake of macronutrient, energy, and micronutrients. It's obesity, diabetes, atherosclerotic heart diseases, hypertension, also insulin resistance, poor clinical outcome, and increased morbidity and mortality. And I mentioned that among patients with diabetes, metabolic syndrome, and obesity, there is very common some deficiency like vitamin D and A deficiency, also vitamin B deficiency, also iron deficiency, B12 deficiency. So there is really a risk of deficiency because usually these people, they consume energy dense foods. It means carbohydrates and bread and cereals, but they don't eat enough fruit and vegetables and lean meat in order to ensure adequate balance of different and adequate intake of different nutrients, micro and micronutrients. This is the selected criteria of metabolic syndrome, different organization, International Diabetes Federation, and this is international criteria of International Diabetic Organization, Federation, and International Atherosclerosis Society, and International Association for the Study of Obesity. But in general, central obesity based on race and gender specific waist circumference cutoff. What are the criteria? If the person has more than 2 of these criteria, it has a metabolic syndrome. It means elevated triglycerides, reduced HDL cholesterol, elevated blood pressure, and elevated glucose. It's glucose, morning glucose level. In this criteria, there are more than 3. It's elevated waist circumference, triglycerides, HDL, and blood pressure. So this is the harmonized criteria, a little bit later, 2009. It's again the same. I mean, waist circumference, because waist circumference, it's an independent risk factor for cardiovascular diseases and for metabolic syndrome. And this is central obesity. It's more than 85 centimeters for women and more than 90 centimeters for men, together with 2 of the following criteria: elevated triglyceride, blood pressure, and glucose level. The new International Diabetes Federation definition for metabolic syndrome: central obesity plus any 2 of the following 4 factors. You see that the criteria are very similar, but different organizations, they selected some specific 2 or more than 2 or more than 3 criteria, but in general, central obesity is one of the factors, one of the risk factors, and very important for assessment of risk, for risk assessment. So raised triglycerides more than 1.5 millimole per liter, or specific treatment for this lipid abnormality. Reduce HDL cholesterol, raised blood pressure more than 130 and more than diastolic pressure more than 85, and raised fasting plasma glucose more than 5.6 millimole per liter. Ethnic specific value for waist circumference. There's ethnic specific, but for race specific. For Europeans and in the USA, they used 102 centimeter for men and 88 centimeter for women, and they are used for clinical purposes. Usually for epidemiological study, we use more than 94% for men and 80% for women. And for South Asian, based on Chinese, Malay, and Asian Indian population, they are a little bit lower, more than 90 and more than 80 centimeters. This is the source is Metabolic Syndrome International Diabetes Federation. Because one of the main risk factors, one of the main diseases that appears among people with obesity and waist circumference, based on waist circumference, is diabetes type 2. Waist circumference should be routinely measured in clinical practice, as it can provide additional information for guiding patient management, and it provides both independent and additive information to body mass index for morbidity and mortality predictions. So only body mass index is not enough, especially, but if the patient is with body mass index over 30, there is no need to measure waist circumference because it provides optimal approach for stratifying patient according to the risk. So if they have high body mass index, but between 25 and 30 body mass index and waist circumference over 92 and over 88 for both sexes, it means it's higher risk. Nutritional risk factors: calorie and protein intake greater or less than the required for age and activity level. Vitamin and mineral intake greater or less than that required for age. Usually in some fat-soluble vitamin, there is increased risk if there is overconsumption by supplementation of vitamins and minerals, especially vitamins. But for water-soluble vitamins, there is not such a big concern because they're eliminated through urine. Also, swallowing difficulties, gastrointestinal disturbances, impaired cognitive function and depression, inability or unwillingness to consume food, restricted diet, and feeding limitation, self-restricted or feeding limitation for some reason. Nutritional risk factors, they can be categorized according to physiological and social factor, cultural or religious factors. You know that in some religion, like also in Orthodox, people are fasting or they have some restriction of some specific food from animal origin 40 days before Easter. So this is religious factors. Emotional disturbances associated with feeding difficulties or so-called emotional nutrition, emotional feeding. People are eating without any need to eat, any physiological stimulation to it. They just eat when they are depressed. Usually they eat sweet things, chocolates and some sweets in order to improve their mood. Limited resource for food preparation, limited or low income, and alcohol or drug addiction. The second one is physical condition. Extreme age, adult older than 80 years, premature infants, very young children, pregnancy adolescents, closely spaced, less than 18 months between two pregnancies, or 3 or more pregnancies. because during pregnancy, if there is inappropriate feeding or nutrition or diet, because the physiological requirements are increased. And for example, for iron deficiency anemia, it's very important to take enough iron during pregnancy, because the iron requirements increase by between 50 and 70% during pregnancy. And if the pregnant women don't take enough iron with diet and with supplements, there is a depletion of iron reserves. And if there is a second pregnancy during the next year, for example, with not enough spacing, there is a risk of iron deficiency anemia, not only for the mother, with a lot of complication of delivery and blood loss and everything, but also for the baby, because there is a risk of iron deficiency anemia for the baby. Alteration in anthropometric measurements, height, weight, or both, fat and muscle wasting, obesity or overweight, and cancer and related treatment. Usually there is a loss of body weight among cancer patients. This is unintended weight loss. And another factors are acquired immune deficiency syndrome. This is unintentional body weight loss, gastrointestinal complication, catabolic or hypermetabolic stress trauma, sepsis, burn, stress, immobility, osteoporosis and osteomalacia, neurological impairment, including impairments of sensory function, and visual impairment. People cannot make proper selection of foods. Also, when there are abnormal laboratory values, for example, visceral proteins, low albumin, low transferrin, and prealbumin. Albumin, usually, it's indicators for more or less long-term protein depletion. And transferrin and prealbumin, they're usual because they have faster turnover protein. They're fast turnover protein, and they can be decreased in patients who are on short-term low protein intake. Also, lipid profile, cholesterol, high-density lipoproteins, triglycerides, hemoglobin and hematocrit, blood urea, nitrogen, creatinine, and electrolyte levels, and fasting serum blood glucose level. So all this can indicate some nutritional deficiency or problems or imbalance. Also medication, chronic use of some medication, multiple and concurrent administration, polypharmacy, for example, or eating this drug-nutrient interaction and side effects. That's why it's very important, but this is not my problem. This is a more pharmacological problem, when to take the medication, when to take the drug, before eating, on empty stomach, or after eating, or between two food intakes. This is the nutrient screening assessment form. It's, I don't know if you can read this, but you can download it from the internet. So this is the first screening assessment form, and this screening form should be completed during the first visit in hospital. This is weight, normal weight, medication, appetite, usual body weight, the percentage of loss of body weight also, and some factors that can influence. This is the form during admission. A loss of appetite, difficulty of chewing, significant food allergy, for example, appearance, malnourished, pale face, or edema also. Length of hospital stay should be also monitored. year more than 65 years of old. Consumption of meals, 50% milk consumption, and modified diet if the person is on a restricted diet or exchange diet or something like this. Nutrition screening precedes the nutritional care process. The purpose is to quickly identify individuals who are malnourished or at nutritional risk. It can be completed by nurse, dietetic technician, physician, or other qualified health specialist. After the screening, patients who are at nutritional risk are usually referred to registered dietitian who prepare individualized recommendation or dietary regime for this person. What are the requirements to nutritional screening tool? It should be simple, easy to complete, inclusive of routine data readily available. It should be also cost effective, nothing special, effective in identifying nutritional problems that require further assessment, and reliable, consistent between measure of the same factors such as weight and valid. I mean, in our hospital, maybe we can use only the weight during the hospital stay. And if the weight is decreasing, has been decreased, and it's lower compared to the day of admission, this is not a good sign of hospital care. The major criteria used for nutrition screening are patient history of weight loss. This is one that is very important and very indicative, because some patients they put themselves on diet, and this is an intentional weight loss, or doctors, medical specialists are recommended dietary approach in order to reduce weight. This is one. And the other patient, they have unintentional weight loss, and this is usually cancer patient with some chronic diseases. Also, the screening form include current nutritional support, if there is such a support. Skin breakdown, poor intake, chronic use of modified diets. Modified diets, it can be a diet with low energy intake, but it can be also with low fat intake, for example, for pancreatitis and liver diseases, or with low protein intake for kidney diseases. Additional information for nutrition screening: the setting in which the information is obtained, home, clinic, hospital, life cycle or disease type, acute or chronic, available data, definition of risk priorities, and the goal of screening process. And for example, this is a very simple screening criteria for potential nutritional risk for pregnant women: antepartum, obstetric condition, multiple gestation, intrauterine growth retardation, diabetes, hyperemesis, anemia, chronic system condition affecting nutritional status. This is the first one. Adolescents less than 17 years, because they have higher requirements, because their body is in development, in the process of development. Low albumin level, lack of knowledge about pregnancy diet, and there are no advice or consultation or support from family. Inappropriate weight change, therapeutic or limited diet, and length of stay in hospitals more than 5 days. Postpartum, weight gain, expected weight gain. This is also for screening criteria. Cultural, social concern, activity level, plan to breastfeed, yes or no, diagnosis, if they have some specific diseases, age, pregnancy weight, body mass index. Maybe you remember from, this is you remember from your second semester hygiene lessons that the recommended body weight gain during pregnancy, if the initial body mass index was normal, was between 11 and 16 kilograms during the whole pregnancy. It means during the second and third trimester of pregnancy, per week, it should be not more than 400 to 500 gram weight gain. This is a normal. If the woman is with overweight or obese, there is enough to weight gain around 11 to 12 kilogram during the whole pregnancy in order to ensure delivery of normal babies. So it's preliminary body weight assessment before pregnancy is very important in order to recommend normal body weight gain. For example, during the third trimester of pregnancy, it's not recommended to gain more than 1 kilo, even less. So there is no risk if there is no weight gain during the first 3 months of pregnancy. So it's very, very specific. Malnutrition universal screening tool must. You can also, maybe I can upload it for you, but you can download from internet. Must is designed to be used by multiple disciplines rather than by a specific group of professionals. So being a clinician, being a physician or surgeon or obstetric or gynecologist, you have to use these tools. 3 independent criteria are used: current weight using body mass index, unintentional weight loss using specific cutoff points, and acute disease effect on nutritional intake for greater than 5 days. The 3 components are used together to predict outcome rather than individual components. So you have to combine them. Once the scores are added, the overall risk of malnutrition can be determined using 3 categories. If there is a 0 score, low risk, 1 is medium risk, and 2 and above is high risk. And this should be, and this is the must universal screening tool. Step 1, for example, based on body mass index. If the body mass index of the patient is between more than 20, it's 0. If it's between 18.5 and 20, it's 1. And if it's more than 18.5, it's 2. It means it's undernutrition. It's low body weight. The second one is unplanned weight loss during the previous 3 to 6 months. If there is less than 5% of the initial body weight, score is 0. If it's between 5 and 10, score is 1. And if it's more than 10, the score is 2. And so management guidelines, there is also a specific management guidelines. And usually if there is a low risk, routine clinical care and nutrition education and dietary advice, general dietary advice. If there is a medium risk, it's actually some specific recommendation. And if there is a high risk, there is a need of treatment of malnutrition with specific oral supplements and specific well-controlled diet. The malnutrition, so this is again the same. Acute disease effect score at a score of 2 if there has been or is likely to be no nutritional intake for 5 days. So, but if there is acute disease, there is also high risk because it can happen. The requirements, nutrition and dietary requirements are high. If there is a low risk, clinical care in hospital weekly, in homes monthly, based on body mass index, it means based on monitoring of body weight, but not more often than once per week. Community annually for specific groups, but now we are talking about hospitalized patients. If there is a medium risk, document dietary intake for 3 days each subject in hospital or care home. If improved or adequate intake, little clinical concern. If no improvement, clinical concern, follow local policy. Repeat screening in hospital weekly, care homes at least monthly, and community at least every 2 to 3 months, and specific calculation of energy intake and protein intake. This is the most important. The first step is energy and protein repletion. And if there is a high risk, refer to the dietitian, nutritional support team, or implement local policy. Improve and increase overall nutrition intake. And if the overall diet cannot satisfy the increased nutritional risk, there is need for oral supplementation. We'll talk about that later. Nutritional and assessment, comprehensive evaluation carried out by a registered dietitian for defining nutritional status, medical, social, nutritional, medical medication history, physical examination, anthropometric measurement, and also laboratory data. Nutritional assessment is the first step in the nutritional care process. So this must evaluation form and nutritional assessment. Goals for nutritional assessment: identify individuals who require aggressive nutritional support, restore and maintain individual nutrition status, and identify appropriate medical nutrition therapy. Malnutrition is not uncommon in those who are obese, cachectic, older, or have undergone trauma, and in whom nutritional intervention is neglected. Level 1 screening, it's simple. Body weight and height, calculation of body mass index. Check any boxes that are true for the individual. Has lost or gained 4.5 kilogram or more in the past 6 months. If the body mass index is below 20, if the body mass index is more than 27. Eating habits, living environment, and functional status. And this is the nutrition assessment and risk level form. So here you have to calculate the body mass index and also the dynamic of body weight loss or weight gain during the last couple 3 months, 6 months before the examination. Medical history, present and past illnesses, current health, allergies also because people avoid some foods, past or present surgeries, family history of disease, psychosocial status, alcohol and drug abuse. This is the sample nutritional assessment form, and this is actually, this question include the previously question. This is the most important. How the physical status and how the usual dietary approach or selection of food has changed in order to change nutritional status. Nutrition and diet history: anorexia, it's augasia, loss of sense of taste, dysgeusia, diminish of distort taste, anosmia, loss of smell, and excessive alcohol intake. Malnutrition is very, intended nutrition and malnutrition is very common with alcoholism. Poor fitting dentures. You're not specialists in dentistry, but you have to look or to ask what is the denture status, stomatological status of the patient. Fat diet eating, chewing and swallowing problems can increase the risk for gastrointestinal diseases or also for malnutrition. Frequent meal away from home, this is also a risk factor. Adverse food and drugs intervention, inability to eat for some reason, for example, for more than 7 to 10 days. For example, food-borne diseases, diarrhea or vomiting, some infectious diseases, or carcinoma or something like intravenous therapy for more than 5 days. So this is also a risk factor. So refeeding should start as soon as possible after surgery. Normal enteral feeding should start early. This is the new idea. Dietary intake, the dietary history, best means of obtaining dietary intake information. You have to ask your patient, usually in outpatient clinic, most accurate dietary food record or diary. This is, you are encouraged or you are advised the patient to write everything that he eats, and individual intake can be calculated for usually for 3 to 7 days, but this is especially for outpatient. Inpatient in hospital, it's not very common. Also, food frequency questionnaire, this is a retrospective review of intake frequency per week, per day, per month. So you have to ask, how often do you eat, for example, do you drink milk or do you eat meat, or in order to evaluate if there is a risk of protein malnutrition, so protein dense foods. Dietary history, best means of obtaining dietary intake, 24-hour recall, data collection, the specific food and drinks in the amount consumed in the past 24 hours. Problems associated with these methods are inability to recall accurately the kinds of amounts of foods, difficulty in determining whether the day being recalled represent the individual's typical intake, usually, because it's a big variation, day per day variation, and also individual per individual variation. And concurrent use of food frequency and 24-hour recall questionnaire improves the accuracy of intake estimates. But in hospital, usually we are not using. This is a good example for food frequency questionnaire. This is very easy because you have the list of foods of concern, and this is the frequency of consuming these foods. For example, if you have a person with cardiovascular, for example, infarct, myocardial cardiovascular accident, or cardiovascular diseases, you have to ask how often do you eat fatty meat or fatty fish or sugary foods, or do you eat a lot of butter or lard, or so how often? And if he says that he prefers, for example, pork meat or meat products every day, and he consumes this in huge amount, for example, 200 or 300 portion size, it means that maybe this is somehow related to food model, to nutrition model. Then you have to make a nutrient intake analysis. There are specific tools, and usually there are a computerized program in order to convert foods into nutrients. So there is a food composition tables, and food composition tables, they contain the chemical composition of food, and they are transformed into nutrients. Anthropometric measurement. Usually we are, it's important to measure, not just to ask the person about his health, because, for example, people older than 65 years, they decrease because of osteoporotic changes in their bones. They decrease their height. So if he has a height of 180 centimeters when he was a student, it means that at least 4 to 5 centimeters less is at the age of 65 and older. Measure weight at admission, current and usual. It reflects recent nutritional intake. It provides crude evaluation of overall fat and muscle stores. Determine percentage of weight change over time. Weight pattern. This is important. How the reduction of weight is happened during the specific period of time, last month, last 3 months, last 6 months. Determine percentage above or below usual of ideal body weight. Reference standards are based on statistical sample of the entire specific population. For children, we are using this growth chart, and this is the growth chart that used based on WHO. Height for age, length for age, weight for age, and weight for length curves. And they're used when you put the current height for age, for example, height for age and length for age for children younger than 12 months, and weight for age. It's very specific, and it changed this criteria, this indicator. It changed during the short term undernutrition. This is the length for age for girls, birth to 6 months of. This is the length, and this is the age. So this is the normal. This is between 15 and 85 percentile. This is the normal distribution. And if the baby is somewhere here, it means it's normal. And if it's below the 5th percentile, it means it's malnutrition. And this is overnutrition and obesity. Over 97 percentile, it means obesity. So weight is easy to obtain. Ideal weight for height for reference standards is no longer used, but it's used usual body weight. For example, if the patient says that he was, for example, 55 kilograms for more than 20 years, and during the past 6 months, he reduced 5 or 6 kilograms, it means that you can compare the changes, the dynamic with the usual body weight. Comparing the present weight to the usual body weight allows weight changes to be assessed. It depends on the patient memory, of course. Actual body weight is the weight obtained at the moment of examination. Weight loss can reflect dehydration, but also can reflect the immediate inability to meet nutritional requirements and may indicate immediate risk. The percentage of weight loss is highly indicative of the extent of severity of individual illness. And this is the criteria for determining the percentage of recent weight loss. You have to use these slides when you are working on the final case at the final of this presentation. So significant weight loss is 5% and more in 1 month compared to usual body weight. 70.5% of loss in 3 months. It's significant, and 10% loss in 6 months is also significant. If the person was, for example, and this is unintentional body weight loss, but also intentional body weight loss. If the patient with metabolic syndrome was on diet, usually the recommendation is, you know that people with diabetes type 2 and metabolic syndrome and overweight, usually the first level suggestion or consultation or recommendation is to lose weight, to reduce weight by 5 to 10% in order to improve glycemic response. So firstly, if the person is 100 kilograms, so he has to change by 5 to 10 kilograms his body weight, to reduce by 5 to 10 kilograms his body weight for 6 months, for 6 between 6 and 12 months. So this is intentionally, this is something positive, but you have to check the vitamin D status. This is the first and most important you have to make if the person is on diet. And severe weight loss, more than 5 for 1 month, more than 7.5 for 3 months, and more than 10 for 6 months. A criteria based on current weight as a percentage of usual. Minimum weight for survival is 48% to 55% of usual body weight. So this is also a criteria. Mild malnourished, between 85 to 90% of usual body weight. Moderate malnourished, between 75 and 84, and severe malnourished, less than 74. And minimum weight for survival is 48 to 55. Body mass index, you know this, you are familiar from physiology, pathophysiological index. This is, you require only weight and height measurement, but you have to measure it during the first visit. It can indicate overnutrition and undernutrition, accounts for difference in body composition by defining the level of adiposity and relating to its height. Body mass index can be calculated using any of the following formula. Metric formula is body mass index, weight in kilograms, and the square meter. This is the height in meters. It means that if you are 170 meter high, 1.7, the square of 1.7 meter. And this is the English formula if you want to make it in pound. Body mass index can be calculated plotting on a growth grid used with children aged from 2 and people to 20 years old. So this is the grid, and this is the same. This is the body mass index, and this is also the kilogram. This is also the body mass index, and this is the age. So you can use also this. This is the state. This is, I think it's CDC criteria. And yes, there are CDC criteria and grids that can be used. So you can make your life easier and put the results of your measurement on plot. Informativeness of body mass index has the least correlation with body height and the highest correlation with independent measures of body fat for adults, including older adults. So it correlates, it's accepted that it correlates with body fat. And that's why it's used for risk assessment. Body mass index does not measure body fat directly, but correlates with the direct body fat measurements, such as underwater weighting and dual DEXA measurement. Body mass index ranges are based on the relationship between body weight, disease, processes, and mortality. It means that the classification is less than 18.5 is undernutrition, malnutrition, undernutrition actually. Adequate body mass index is between 18.5 and 45, 24.9, and overweight is between 25 and 29, and obese is more than 30. Although a strong correlation exists between total body fat and body mass index, individual correlation need to be recognized because there are differences in race, sex, and age. Also, they must be considered. Body mass index increase with age, and it increased the fat mass and not the lean body mass. In association between body mass index and mortality for non-hospitalized patients 65 years of age and older, data do not support the body mass index of range 20 to 27 as a risk factor for all cause of cardiovascular and cardiovascular mortality. It means that for people 65 and over 65, it's better to be a little bit overweight, it means 20 to 27. Between 25 and 27 for your age is overweight, but for my age is actually better. The guideline standards for ideal body weight may be too restrictive to older adults. So among older adults, there is a risk between 18.5 and 20 body mass index, especially for infectious diseases. And this is the calculating, this is the example. You can practice this if you want, especially for the patient, for the cases I will send you. Body composition. Body composition, this is a skeletal size and proportion of lean body mass can be contributed to body weight variation among individuals of similar height. It means that skeletal size and muscular athletes may be classified as overweight because of their excessive muscle mass. And older adults have lower bone density and therefore may weigh less than younger adults of the same age. And that's why we are using body composition, some measurement of triceps skin folds, some skin folds, and circumferences. Triceps skin fold, mid-arm muscle circumference, and mid-arm circumference. And these circumferences and skin folds, they express subcutaneous fat. So this fat fold or skin fold thickness measurement is a means of assessing the amount of body fat in an individual. And there are specific criteria. Subcutaneous fat skin fold thickness, if changes are going to occur, they take 3 to 4 weeks. It means that during a hospital admission, they cannot be changed. The measurement base total body fat estimates on the assumption that 50% of body fat is subcutaneous. Accuracy decreases with increasing obesity. The most reflective of body fat in skin fold sites are over the triceps and the biceps, below the scapula, above the iliac crest, and the upper thigh. The triceps skin fold and subscapular measurement are the most useful because of existing standards. And you are comparing the results with the standards. And this is the diagram. This is the picture skin fold measurement in millimeters. And also there is also age dependent. And this is the normal, this is low, it's a normal, and this is in between, a moderate. So if you have standards, you can select the most appropriate indicators in order to ensure that your body fat reflects, your body mass index also reflects the body fat. The fat distribution is an indicator of risk. Circumferential measurement are used more frequently. The percentage of excess body fat around the abdomen or of proportion to total body fat is considered a risk factor for elements associated with obesity and metabolic syndrome. And we already said that waist circumference measurement are often used and there are independent risk factors. This is something a little bit oldish, waist to hip ratio. The older method, waist to hip ratio, is used to detect possible sign of excess fat deposition, lipodystrophy in those infected with the human immunodeficiency virus. It's used less often today, and the ratio of 0.8 or above indicates risk in women, and 1 is above indicates a risk in men. So in people with HIV, there is a redistribution of fat. This is very typical. Lean, it's starvation, it's undernutrition, but with redistribution of fat. Waist circumference is measured with a non-stretchable tape, measured below the rib cage and above the umbilical. A measurement greater than 102 and 88. And the measurement but not be useful for those less than 152, tall and with body mass index more than 30 or above. In obese person, it's not an indicator. Other measurement, this is for children, head circumference, calf circumference measurement or calf circumference combined with other anthropometric measure can be used to estimate body weight in older adults. There are also standard and total body potassium. Hand grip dynamometry, especially for undernourished patients, provide baseline nutritional assessment of muscle function by measuring grip strength and endurance. It's useful in serial measurement. Measurements are expressed as a percentage of a standard for men and women. So there are specific dynamometers and hand grip dynamometers, and they are used to measure in a non-dominant hand. And these are the criteria. You will see this also. You practice this in hygiene lessons. Also, hydration is very important, and you have to ask person about hydration or dehydration or edema. From the history, loss of water and electrolytes from vomiting, diarrhea, excessive laxative abuse. Some people, for example, people with bulimia, or especially bulimic girls, they use excessive laxative abuse in order to reduce their body weight. Fistulas, polyuria, fever, excessive sweating, and edema also. A fluid volume deficit can also be caused by decreased intake, which may be prominent in those with anorexia, nausea, depression, and inability to gain access to fluid. Fluid volume deficit associated characteristic: weight loss over a short period of time, decreased skin and tongue turgor. So you have to check about the turgor. You know this from your internal medicine lesson. Dry mucous membranes, postural hypotension, weak and rapid pulse, slow filling peripheral veins, decrease in body temperature, decreased urine output. This is a compensatory. Elevated serum creatinine and hematocrit. All these factors should be taken into account when you are assessing nutritional status and where you think that fluid volume deficit should be the reason. This is classification of protein energy malnutrition. This is the International Code of Diseases. Diagnosis and description: kwashiorkor, nutritional edema with dyspigmentation of hair and skin. Kwashiorkor, normal anthropometric weight, more than 90% of the standard weight to height. Depressive, but at the same time, there is, because here there is an edema, nutritional edema, and normal anthropometric weight is not indicative for, it can, because of the edema, there is a normal body weight. So, but depressed visceral protein, concentration of serum albumin less 3 grams per deciliter, and transferrin also less than 180 grams per deciliter, caused by acute energy and protein deficiency or a metabolic respiratory injury. So in this situation, maybe transferrin is more sensitive because the reason is acute. And characterized by edema, catabolism of muscle tissue, weaknesses, neurological changes, and so on. Marasmus, nutritional atrophy, severe chronic calorie deficiency. Depressed anthropometric weight. This is a chronic, and the previous was acute. And more than 80% of standard deviation. Weight loss more than 10% of usual weight in the last 6 months. This is, remember the previous slide. Relative preservation of visceral protein caused by chronically deficient of energy intake. This is more energy and not so, energy and protein, but it's combined energy and protein, so not so serious protein deficiency. This is other severe protein energy nutrition with edema, depressed anthropometric, depressed visceral protein. This is also already protein. Occur when patient with marasmus is exposed to stress, trauma, surgery, acute illness. And if there is such a situation before surgery and in a situation with planned surgery, it's very important to restore or to reestablish a little bit better nutritional status. It's characterized by combined symptoms of marasmus and kwashiorkor and high risk of infection, poor wound healing. In this situation, there is a zinc deficiency also. This is the malnutrition of moderate degree, depressed anthropometric weight, relative preservation of visceral protein, and depressed anthropometric preservation of visceral proteins. So in this patient, there is a low food intake, but there is no specific low protein intake. So it's low energy, and the result is depressed anthropometric. And at all stages of care, you have to obtain consents for screening and assessment and intervention. In this patient, intervention is very important. Consider cultural, ethical, and legal issue, and ensure that there is a care pathway for clear treatment goal. Determine malnutrition risk using validated screening tool, and undertake assessment of reason for risk using nutritional assessment form. And treatment, nutritional assessment, advice on method, give healthy eating nutritional if there is a low below, unintentional weight loss, not more than 5%, only adequate variety of food, fluids, and energy intake. The second one is treatment nutritional assessment, moderate, consider referral to dietitian, high protein, high energy diet and snacks, oral nutritional supplements, and set patient-centered goal every 2 to 4 weeks. And recommend 5 food and fluid diary in order to see if there is compliance with recommendation. Nutrition assessment show high risk, strong consider referral to dietitian, high protein, high energy diet and snacks plus oral nutritional drinks. It's very important to check everything based on 2 to 3 day evaluation of diet and record weekly weight every week. And this is the oral nutrition supplements. Some of them can be high protein, indicated where protein requirements are high. Research indicate that oral nutrition supplements are superior to standard diet in meet protein requirements. Maybe you know these 5th grade students, maybe you are familiar with frizubin, different shakes or pulvers that are in additional put in food or used in like shakes and snacks. And actually they contain 1.5 to 2 kilocalories per milliliter, and some of them provide 20 gram protein in 170, for example, desserts. Kidney liver disease. There's also some patients are indicated for oral nutrient supplements. In patients with kidney failure disease, it's strongly recommended they have a referral for individual assessment by dietitian because they have to reduce protein intake. Also malnutrition and cancer cachexia. Omega-3 fatty acids and different short-term and 3-omega fatty acid supplements are indicated for people with cancer cachexia. And this is the fluids between 20 and 30 kilocalories per kilogram per day, 1,500 to 300 milliliter per day. This is the calculating nutrient, a basic guide. Use it when you are working after next week with your patients. And this is, there are sterile liquids, semi-liquids, widely used within the acute and community health, and may be prescribed in the support term during acute illness, but also for individuals with long-term chronic conditions. Usually, I am suggesting this for people after bariatric surgery, because they need to take more protein. They need to take at least 60 to 75 gram protein per day, and to reduce their energy intake. It means they need something that is protein rich, protein dense. So, and also for people with cachexia after surgery of gastrointestinal tracts, especially in the role of its complement nutritional intake, available on prescription, contain micronutrients, and they are not complete and cannot be used as a sole source of nutrition. And they are used in short bowel syndrome, dysphagia, intractable malabsorption, preoperative preparation of undernourished patient, inflammatory bowel diseases, total gastrectomy and in fistula. I remember the word. Sorry. And it's very important, especially in fistula of gut. And disease-related malnutrition. And here are some examples. You can check, because they're in different countries, they have different oral nutritional supplements. You have to check and to calculate, especially you're calculating the energy and the protein intake, especially for let's say short-term use, 1 to 2 to 3 months supplementation. When there is a need for longer supplementation, maybe you can use also supplements of vitamins and minerals. Here are semi-solid for dysphagia, high protein, low volume, high concentration. For example, fat and protein-based products that are taken in small quantities, like shots, typically 30 to 40 milliliters, 3 to 4 times per day. High protein, jellies in shot, milkshakes, they contain 11 to 20 grams of protein in volume ranging from 30 to 200 milliliters. Frisubin shakes, there are 200 milliliters, and they are available. You can look, this is a Frisubin, you can look it. Use with caution, because especially in people with dysphagia, to ensure the correct consistency. There is emergency groups of these supplements, individual over the age of 65 who can be at risk of vitamin D deficiency, and special medical conditions. A patient with short gut may not tolerate hyperosmolar oral nutrient supplements, as they may increase stomal losses. And this is really a serious problem. Monitoring, dietary intake, body mass index, compliance with diet. Individual can no longer tolerate them due to taste or fatigue, so you have to change and to adapt it. And this is restoration of nutritional status is something very specific, and it should be individualized. This is a clinical scenario 1, and you have a clinical scenario 2. That's why 1. No, okay, this is still 1. This is the clinical scenario 2. And this is a lady with diabetes and obesity. And this is a person with undernutrition and malnutrition. And because next Saturday, we have a lecture about refeeding syndrome and how you should change and exchange and replace some foods and fluids and everything in order to restore nutritional status. You can read this presentation and try to calculate the changes in nutritional status. But before answering all the questions, please wait the next lecture, because you have to use this. Okay. And what is, because in order to develop a nutritional assessment questionnaire and nutritional assessment plan for this person, you have to finalize the next two presentations. So next time I'll provide the next two, and also I'll provide the list for individual tasks, and you can select. But when you decide what are your plan for developing individual development, please send the title or send them the topic of your selection, because I have to prepare the list, and then for me it will be easier to evaluate, not to make it in the last moment. Okay, if you have any question, if you don't have any question. Okay, are you, Carolina? Are you here? Sound perfect. Okay, okay. Have a nice weekend. If you don't have another elective disciplines in the afternoon, enjoy. And okay, I'll try to make your life easier. Not maybe students from grade 5 know that I have not too high expectation from hygiene, but higher than you were ready to deliver. But this time really it's elective, it's volunteer, and I really would like to encourage you to participate, or at least to read my presentation, because I'll upload everything in your system, so everything will be available. And also I think that also for younger students from grade 3 and for you, try to use this in your clinical exercises. When you have access to patients, try to ask them about not only diagnosis, not only symptoms of diseases, but also nutritional habits. Why do they eat too much fat or too much sweets, or how they gain weight, for how long do they gain this weight? Do they have some changes in laboratory measurement, like high cholesterol or high triglycerides? Because high cholesterol, it expresses more high fat intake, saturated fat intake, and high triglycerides should be more a sign of too many sweets and too many sweet things, sugary things, and also soft drinks. So try to think about, okay, when you have contact with your patients. Okay, bye. See you next time. Thank you for joining.